I'm delighted to be here. Thank you so much for inviting me. And we have like a little over an hour, and I wanted to spend the time introducing addiction, both from a historical perspective as well as talk about treatment, in particular medications for opioid use disorder in pregnancy. And I wanted to begin by, like a historical perspective, and really note that most people and most cultures have used substances. In fact, it's really hard to find. There's only one culture that didn't use any substances, and it's a group of people who today live in Papua New Guinea, and the island they lived on, the plants did not produce what we call ethogens, compounds that cross and interact with the brain. And you're probably well aware of the ancient sort of travel and trade, in particular in alcohol, as depicted here on the map of all the different places alcohol was sort of invented, distilled, and then traded. But it's not just alcohol, because both cannabis and opioids figure into the historical record of all societies and all cultures that had any kind of medical writing. But whereas, substance use is ancient and can be considered to some extent part of human culture and human creativity, the idea of drug problems and addiction are actually a relatively modern phenomenon. And they date, the first drug epidemic was alcohol in the 1700s. And this was due in part to the advent of distilled hard liquors, we'd call them today, in particular gin. And you can see here on the left, this lithograph features a woman front and center sort of neglecting a child. So in images of alcohol, even from the original epidemic, women are figured prominently. And at this time, people understood addiction as an illness. Dr. Benjamin Rush, who signed the Declaration of Independence, among other things, was a physician. He wrote this text here in which he described alcoholism as a medical condition to be treated by physicians. And similarly, people with the disease of addiction were understood and treated with compassion, as witnessed here from this quote from Abraham Lincoln when he spoke to the Temperance Society of Springfield, Washington. The victims to its spirits were pitied and compassionated, just as now are other hereditary diseases. In my judgment, such of us as have never fallen victims have been spared more from the absence of appetite than from any mental or moral superiority over those who have. So addiction was not only understood as an illness originally, but what we call today sort of stigma, discrimination, prejudice against people with the condition of addiction is a more recent phenomenon. So alcohol was the first crisis, the first epidemic of addiction. And the second were opioids. And these arose sort of in the latter half of the 1800s into the early 1900s. And this was really understood at the time and truly was a disease of women. And these are images of people with an addiction to opioids at that time, white, upper class or upper middle class women who had been initially exposed to opioids from their physician, as witnessed here from this textbook from the turn of the century. Within a few years, many authorities have pointed out the danger of morphinism in women who come under treatment for gynecologic disorders. And this disease was called morphinism using the framework of Dr. Benjamin Rush, where he described things as alcoholism, and it was seen as a medical condition and it was treated like one. In fact, physicians specialized, some of them, in the treatment of opioid addiction, and they utilized opioids for the treatment of what we'd call today opioid use disorder. In fact, morphine was synthesized first, followed by heroin, and one of the first clinical utilizations of heroin was for the treatment of addiction to morphine. And it's from this era, the turn of the century, that neonatal abstinence syndrome is first described. And I think it's interesting, too, that not only were physicians involved in the care of people with addiction, but so were police departments. And police departments actually had, some of them embedded in them, morphine clinics to provide medication for people with opioid addiction. So that was the first opioid crisis. And I think you are all well aware that we are in, depending how you count, the third or the fourth, but certainly the greatest crisis of opioids in our country's history. And it bears a lot of parallels to that first crisis, in part because, one, it features a large proportion of women, and two, it's iatrogenic in origin, which means caused by physician practice, at least in part. And this is the figure that CDC released in 2011 that really labeled the crisis as a crisis. You see the volume of opioid sales increasing, the volume of drug treatment admissions, a parallel rise, and an parallel increase in opioid-related overdose deaths. Now, there's no question that we overprescribed opioids, but it's important to know that most people who were chronically prescribed opioids did not develop addiction. And there are several systematic reviews on this topic area, and I just picked one. All of them have very similar findings. And this is looking at individuals who had been prescribed opioids for 12 months or more. And whereas perhaps a third reported misuse of opioids in that period of time, that means taking more than directed, running out early or something like that, only 10% roughly of individuals would meet criteria for actually having an addiction. Now, that's not 100% and that's not 0%. And because we prescribed so many opioids for the last 15, 20 years, that 10% turns out to be a very large number of people. But it's important to know that most people who use a substance do not become addicted to it. And we've known this for decades, actually. This is one of the first articles on this. And you might have heard people talk about how, quote unquote, addictive a substance is. And that's based to some extent, one way you could look at it is data like this. And you come up with a percentage as seen here in this figure. And it's a percentage that's derived from a fraction. And in the numerator is the number of people who used that substance in the past year. And the the numerator is the number of people who meet criteria for the use disorder, and the denominator is the number of people who used in the past year. And you can see from this, about 32% of people who smoked a cigarette in the past year have a nicotine use disorder. About 25% of people who used heroin have an opioid use disorder, and it decreases from there. So most people who use substances don't have an addiction to them, or don't develop an addiction. And this is a really fascinating question. Why do some people become addicted and not others? And this is not the topic of this talk, but I will say there's a huge amount of research and interest in sort of understanding this. There's a genetic and biological contribution, and there's a very strong environmental one. And within the environment are things like age of first use. We know the younger somebody is that's exposed to something, the greater the likelihood of developing an addiction to it. We know that people with adverse childhood experiences, trauma, and etc., PTSD, are more likely to develop a substance use disorder compared to people without. There's a lot of associations that we have, and these are critically important when we think about prevention. So, since the CDC published that one figure, prescribing has actually been declining in the United States, in almost every part of the country. And probably prescribing peaked sometime around 2010 or 2011, and it's dropped by about 25 or 30% since then. It's still several times higher than it was in the 90s, but it's decreasing. Despite this change in prescribing behavior, overdose deaths keep increasing. And that's because the crisis is not really as much about prescription opioids now as it was previously. And we talk now about a triple wave epidemic. The first wave really being the prescription opioid piece. The second wave starting in 2010 as prescription opioids sort of decline and it's heroin. And the third being what we call fentanyl or synthetic opioids, which are illicitly manufactured and enter into the drug stream and really contaminate the drug stream and are multiple times more potent than heroin or prescription opioids are, and that's what's really driving the overdose crisis at this point in time. But the mortality from opioids is not gender equal, and even though more men die of overdose than women do, the rate of increase is greater for women than it is for men. And it's not just opioids. These are data from CDC contrasting 1999 to 2017, stratified by age, and you can see a marked increase in prescription opioid deaths, an even larger increase in synthetic opioid deaths, but you also see increases in deaths related to antidepressants, benzodiazepine, and cocaine. So, I don't think I need to tell you guys that as the population of people in the United States used more opioids, a subset of them developed an addiction to opioids, and a subset of them became pregnant and stayed pregnant. Because we've seen a marked increase, a tripling at least, of the rate of opioid use disorder at the time of delivery. And there are many sort of sequelae of that. And one of them that people have paid a lot of attention to is neonatal abstinence syndrome. And this here on the left, these are data from Georgia, and you can see a marked increase, in particular in the last couple of years, related to NAS. Some of this is definitely driven by an increase in cases, but some of this is also being driven by an increase in counting things. So there were probably more cases in the past because not all hospitals reported as they do now. So this is important to increase, but this rate of change captures both what's actually happening as well as how we are counting things. But it's also, again, important to keep in mind that it's not just the opioid. In fact, there are multiple other substances, in particular stimulants and cannabinoids, that are present in the toxicology of women and the infants who develop NAS. So, I want to walk through some data. I want to really ask the question, like, what happens when women who use drugs get pregnant? And I'm looking at this from the National Survey of Drug Use and Health data. The blue are non-pregnant reproductive age people. This is past month use, and each of the colored columns is by trimester. And you can see overall that people who aren't pregnant report more past month use than people who are pregnant. You can see people cut back during the course of pregnancy, the biggest change kind of being when you find out you're pregnant to sometime in the first trimester, and it differs by substance. People cut back alcohol the most, cigarettes the least, and illicit substances, which are about 80% cannabis, somewhere in between. So I look at these data, and to me they support the statement that all pregnant women are motivated to maximize their health and that of their baby-to-be. And nobody thinks that smoking cigarettes while pregnant is healthy, or nobody thinks that, injecting heroin while pregnant is healthy. Some people can stop, and some people can't. Those that can't, they likely have a substance use disorder. You can think about pregnancy as a natural experiment. Most people use drugs. Some people can stop, some people can't. Those that continue to use in pregnancy, they likely have the condition of addiction. So what is addiction? The simplest definition is that it's a brain-centered condition, but the symptoms are actually behaviors. Craving a substance, compulsive use of a substance, inability to stop using it, and really the salient feature is continuing to do something that you know is harmful to yourself and others and being unable to stop doing it. continuing to use something in pregnancy is really pathognomonic for addiction. Now, a very important distinction is between addiction and dependence or tolerance. So addiction is not dependence and addiction is not tolerance. Dependence means that when you stop using a substance, you get withdrawal symptoms. And tolerance means you have to increase the dose of something to maintain its effect. Both of those are true of opioids. Both of them are true to some extent of alcohol. They're not true of all substances to which people develop addictions. They're not really true of stimulants. And they are true of lots of medications that we prescribe people. They're physiologic and pharmacologic principles. For example, people who are prescribed antidepressants develop dependence to the antidepressant. And if you stop the antidepressant, they will have withdrawal symptoms. That's dependence. That's not addiction. And the other thing is that when we think about what neonatal abstinence syndrome is, it's dependence followed by withdrawal at birth. It is not addiction. A newborn cannot be addicted to a substance. It can be dependent, but it can't be addicted. Addiction is a brain-centered condition, and the symptoms are behaviors. Craving a substance, compulsive use, continued use despite adverse consequences. Those are behaviors that make absolutely no sense to apply to a newborn. So when we're talking about pregnancy and substance use, what we're really talking about is where the reproductive health life course, people getting pregnant, staying pregnant, delivering a baby, intersects with the addiction life course, use, misuse, and addiction in this specific life course moment of pregnancy. So people with addiction, with the disease of addiction, they need treatment. And the gold standard is integrated care, comprehensive co-located services, bringing prenatal care into drug treatment. And the core components of addiction treatment are medication when it exists, and it does for opioids, plus counseling. And the principles of medication were first described in the 1960s with the original research into methadone. So we've known this for well over 50 years, that how medications work. And this article really describes very well what an addiction to opioids is like. And if you note here, this is people initially, in the beginning, when the first couple, several times, weeks at the most, whatever, that they use opioids, it makes them feel what the authors called high. But over time, as tolerance develops, as the disease, sort of starts to take hold in the individual, they spend most of their time sick, and when they use the heroin, it makes them feel like a little bit straight, but most of the time they're sick. Medication then, and this is the graph of how stabilization looks for individuals who are receiving methadone for opioid use disorder. When dosed correctly, people feel normal. Methadone's a long-acting opioid, so it's taken once a day, as opposed to heroin, which is short-acting and taken multiple times a day. And when we dose medications correctly, people feel normal. They feel straight. So this science that I'm showing you here sort of laid the groundwork, because in the 1960s, there were people who were addicted to opioids who became pregnant and stayed pregnant, and obstetrician gynecologists applied those principles to the care of the patients that they saw. And these are two studies, two of the earliest studies, both of which show the same thing, that by treating opioid use disorder with methadone, these women had birth outcomes that were very much identical to a general population of women without addiction. And here, just to read the conclusion of this abstract, these findings indicate that maintenance of the pregnant addict under closely supervised methadone therapy is compatible with an uneventful pregnancy and birth of a healthy infant whose withdrawal symptoms in the neonatal period are readily controllable. This is almost like blasé. There's nothing, overstated or hysterical. And I would say the tone of this article is quite different from the tone that we have around this topical area today. Now, Loretta Finnegan in this article from 1978 really shows the same thing and operationalizes the difference between treated and untreated addiction. So these are people with addiction here. These are ones who are treated, which is prenatal care plus methadone, and their low birth weight was 19%, which is quite different from the almost 50% of people who delivered without treating, with untreated addiction. And this principle of treated versus untreated disease we see over and over and over again in the literature, and most recently these are data from Massachusetts looking at all substance use disorder, and you can see all of these different birth outcomes are, although slightly higher in treated addiction, depending, people with treated addiction look much more like a population of people without addiction than they look like the people with untreated disease. And this is the core principle of prenatal care. Healthy moms lead to healthy babies. And we treat chronic conditions in order to improve both maternal and newborn health. This is a core principle of maternal child health. Now, the reason why medications for opioid use disorder are so effective in pregnancy relates to that graph I showed you before, how somebody with untreated opioid addiction is using opioids multiple times a day and spending most of that time in withdrawal. And their use just makes them feel less sick than they did before. And it's that rapid cycling of withdrawal that is problematic to the fetus. That's what causes fetal stress. That's what activates the hypothalamic pituitary axis prematurely. That's what leads to low birth weight and preterm delivery. So what medications do is they stabilize the intrauterine environment. There's no more withdrawal happening. It allows for the fetus to grow normally. We think of treatment and medication as sort of a platform for delivering other services such as prenatal care, such as testing and treating HIV, testing, and treating after delivery hepatitis C. And we know that people who are in treatment during pregnancy are more likely to engage in all these other kinds of services. So recently, within the last year, SAMHSA released this document, which is the Clinical Guidance for Treating Pregnant and Parenting Women with Opioid Use Disorder and Their Infants. And if you guys are unfamiliar with it, this is a wonderful document, very easy to use, broken into 4 to 5 pages at the most, subsections that you can use as handouts, that's got lists of resources and etc. And there were 5 main sort of conclusions, and these are the 3 related to medications. Number 1, that buprenorphine and methadone are the safest medications for opioid use disorder in pregnancy. 2, transitioning from one to the other is not recommended. And number 3, medically supervised withdrawal or detox is not recommended. And the reason it's not recommended is that it doesn't work. This is a systematic review that we completed on the entire published literature on detoxification. We found, number 1, there was not a risk of fetal demise amongst moms who underwent detox. That was a historical sort of reason to avoid it that does not seem to be true. But we also found that there was actually no difference in neonatal abstinence syndrome between infants who were detoxed, whose moms were detoxed, versus those that weren't. And that's because when people underwent detoxification or medically supervised withdrawal, their disease recurred. They relapsed, they used opioids, and the infant developed withdrawal. So in many ways, when we think about detoxification is an acute intervention for the chronic condition of addiction. That is a clinical mismatch. That doesn't make sense. We should not be doing acute interventions for chronic conditions. That is a setup for failure. And every single medical society that's ever issued guidance around opioid use disorder in pregnancy supports medication. And there's not a single society that does not. So we know that treatment works in general. This is an article from 2000 that was highly influential that sort of contrasts relapse by different disease states: diabetes, drug addiction, hypertension, and asthma. And you can see that this is one relapse at 1 year. And relapse rates relatively similar across these different chronic conditions. And this is another reason why we say addiction is a chronic disease, because it looks like other chronic diseases. Relapse or recurrence rates are similar across different chronic disease states. So medications are highly effective for the treatment of opioid use disorder in general as well as in pregnancy. Unfortunately, most pregnant people who go to treatment, which is a minority of people with opioid use disorder, don't receive medication. These are data looking at the increase in opioid use disorder during pregnancy amongst drug treatment admissions in the United States, and absolutely no change or maybe even a slight decrease in the proportion who received medications. And most people, like I said, don't get any treatment. And if they get treatment, there's not only no medication, but there may be no specific programming for pregnancy. We looked at this. These are like amongst drug treatment facilities in the United States between 2002 and 2009. And the proportion of any of them that provided any kind of women-centered services declined, as did those that had pregnant or postpartum programming. In fact, in 2010, only about 13% of all drug treatment facilities in the United States would take care of a pregnant person. Since then, there's been a marked increase in, I think, in some parts of the country, and this is in Virginia data, in the number of people who are waivered to prescribe buprenorphine. You can see here, this is from 2016 to 2018, we've had an increase in the number of physicians who are waivered. But there are, within our state, marked disparities remain in terms of access to care. In fact, there's some parts of the state, the more rural parts of the state, like here, the Northern Neck and the Eastern Shore, as well as here in sort of the Central South, in which even if every single prescriber who exists there prescribed at their cap, we would still have thousands of people with unmet treatment need. So, one question that I was asked to help to sort of answer is, how do we identify treatment quality? It's one thing to get people into treatment, but we want to make sure that the treatment that they receive is both evidence-based and person-centered. So in Virginia, we had a benefit through Medicaid in which we reimbursed at a higher rate addiction providers who adhered to particular quality metrics. So one, how do we know somebody is providing evidence-based care? Number one, that they provide and prescribe medication for opioid use disorder. Two, that they monitor the medication with a prescription monitoring program, with urine drug testing, with wrapper or pill counts. Three, that ideally it's co-located behavioral health, but that patients have access to behavioral health services. Four, that the provider is co-prescribing naloxone, which is a medication that can reverse an overdose, that we really can save lives by doing this. And finally, that we're utilizing like either the American Society of Addiction Medicine criteria or more. When we're seeing patients, we're thinking, is my program the best program for this patient at this point in time? Or do they need a higher level of care? Or do they need a lower level of care? And working as a system to help move patients through their recovery and match them to their appropriate levels of care. So that's on the provider sort of evidence-based side. The other way to identify treatment is, does the program address the unique needs of pregnant and parenting people? In other words, is the program welcoming? Do they allow children to be present in the waiting room? Do they have childcare? It doesn't have to be childcare, but just welcoming of children. Is transportation provided for people who don't have it? I mentioned before briefly how adverse childhood experiences and trauma are more common amongst people with addiction. And it's even more common amongst pregnant people with addiction. And so therefore, does the program provide trauma-informed care? And finally, for women, does the program offer or link to reproductive health services such as contraception for people who want it? So those would be the identifiers of treatment quality. And I want to shift gears and talk a little bit about maternal mortality, in particular to talk about the postpartum period. And we've been using the term the fourth trimester to refer to postpartum. And that fourth trimester or postpartum is defined as the year following delivery. So you have the first 3 trimesters of pregnancy and then the year following delivery. And historically, this is like the slide that shows the success of modern obstetrics. This is the likelihood of maternal mortality from the late 1800s to the 1980s. And you can see whereas almost 5% of people died during childbirth 150 years ago, it had dropped to about 1 in 10,000 by towards the end of the last century. But for the last bit of time, our rate of maternal deaths has been increasing in the United States. And for opioids, this is really what's happening in the postpartum period. So this fourth trimester is super important and horribly neglected. This is the time where the mythic image of the ideal mother comes into conflict with what it's really like to take care of a newborn. This is where mood changes are common, sleep disturbances are common. This is where women in prenatal care see their doctor weekly up until they deliver, and then maybe one visit for the following year. Care shifts to the newborn, but newborn visits are less frequent than prenatal care visits were. This is a time where people lose their health insurance. This is not just for Medicaid and not just in states that did not expand Medicaid, but people with commercial insurance can lose their insurance if they need to stay home for a little bit longer to care for a sick newborn or something like that. And this is where really, things start to fall off the cliff. And we know that women with opioid use disorder are more likely to die during their delivery hospitalization. And we don't know exactly why. But they have roughly 3 to 4 times the odds of death compared to people without opioid use disorder. And in the states that have maternal mortality reviews and have looked at the contribution of opioids and other substances to maternal death, such as Colorado here, they've seen that one of the leading, if not the leading cause of death, maternal deaths, is substance related, more common than embolism, infection, hemorrhage, which are the historic causes of maternal deaths. And we should note that not all of these deaths are opioid related, but many opioids are the most common substance, but there's a lot of other substances involved as well. But almost all of these deaths happen in this fourth trimester, in the postpartum period. And we think of overdose deaths as being, like the tip of the iceberg, because for every death there's a whole bunch of non-fatal overdoses and sort of down from there. So these are data from Massachusetts looking at overdose and overdose death through the course of pregnancy, and you can see during pregnancy the rate decreases only to increase postpartum. And down here, this is part B of this figure, you can see the protective effect of medications to treat opioid use disorder on overdose deaths and overdose overall. So just this spring, the National Academies of Sciences, Engineering, and Medicine convened a work group and published this paper called Medications for Opioid Use Disorder Save Lives. And these are their conclusions. 1, opioid use disorder is a treatable chronic brain disease. 2, FDA-approved medications to treat are effective and save lives. 3, long-term retention on medications for opioid use disorders is associated with improved outcomes. 4, a lack of availability or utilization of behavioral interventions is not a sufficient justification to withhold medications. 5, most people who could benefit from medications don't receive it. 6, medication is effective across all treatment settings studied to date. And 7, confronting the major barriers to the use of medications to treat opioid use disorder is critical in addressing the crisis. So I hope that I've showed you how these conclusions in light of the specific population of pregnancy, all of those statements are true for pregnant people as well. But I want to really make the point that the goal of treatment is not more treatment. The goal of treatment is recovery. And recovery is a lot more than abstinence. It's about purpose. It's about integrity. It's about connection to others. It's about meaning. And it is perfectly compatible with the use of medication. So, to conclude, people who continue to use a substance during pregnancy likely have an addiction to that substance. Addiction to disease and medications are core components of treatment. But medications only work if people have access to them. And there's marked lack of access and uptake of medications across the United States. So if we really think addiction is a disease, we need to treat it like one. And that means medication, that means evidence-based care, but that also means person-centered care, which means treating all people with dignity and with respect. So with that, I'm going to stop. There's going to be questions, and I just wanted to alert you guys to this. This is the Clinical Consultation Center. It's a grant-funded program run out of University of California, San Francisco, and it's a warm line that any provider anywhere in the United States can call this number during the times listed there, and they will speak to an expert who can help them both with a clinical care decision as well as a systems care decision. And I want to advertise this line because it's funded by the federal government and it's underutilized. And I think it's a great resource for people who feel maybe isolated in their practice, or just people who just have a question and don't know where to turn to. So with that, I'm going to pause for questions. Thank you.
Thank you, Dr. Terplan. So Gabe, for us to be able to hear you, you'll have to mute your computer and then speak through the telephone. And then for us to be able to respond, you'll have to unmute your computer and then mute your telephone again. So just let us know, or you can also use the chat function so people can ask questions, and then you can type it into the chat function, and then Dr. Terplan could respond via phone. So let us know. Thanks.
What are the long-term effects for babies born exposed to methadone or Suboxone? Is there research to support that MAT exposure is both detrimental to a fetus versus opioid or heroin exposure?
That's a great question. So, let's take a step back. And the operant distinction really is between treated and untreated disease, right? And people with any chronic disease, treatment is better than no treatment. It's not just better for the person, but also for the person as a parent. In terms of long-term outcome, methadone has been used for the treatment of opioid use disorder during pregnancy since the 1960s. We have publications since the 1970s, and there are no good data to show adverse concerning developmental issues. There are no prospective data, i.e. people followed from birth to age 20 or 30 either. For buprenorphine, there is one prospective cohort. The kids are now towards 5 years old, and they were, it's both methadone and buprenorphine. It was the mother study, the follow-up to the mother study, and those kids who are now between 3 and 6 years old, they've continued to be followed. They're being tested with different neurocognitive and developmental tests, and all of their test results are within the normal spectrum. So from prospective data, which is only, as I said, up to about 6 years of age, there's no evidence of any kind of concerning developmental outcome. That being said, I think we tend in this topical area to overstate the potential risks of what an in utero exposure is and really minimize the importance of the caregiving environment. So if we could see cross-sectional data that kids whose moms use methadone perform slightly worse in school, in high school, is that because of the methadone, or is that because of the 12, 13, 14 years of child development between birth and when that measurement was taken? So I think we need to focus on the caregiving environment scientifically more, and most of what we see from substance exposures in general, the effects are subtle. They're not meaningless, but they sort of pale in comparison, I think, to child rearing, child environment outcomes.
Thank you, Dr. Terplan. Another question that came in is, how is this different from methadone treatment, where people tend to become fully dependent on methadone rather than becoming substance-free?
So methadone causes dependence. So do antidepressants. So do medications we use to treat blood pressure, decongestants. Almost all medications that we prescribe cause dependence, which is defined as when you stop using it, you have withdrawal. So in and of itself, dependence is a pharmacologic principle, and in and of itself is not necessarily harmful. I think the question, though, is less about dependence versus addiction, and more about what we think recovery is. So people have different definitions and their own definitions of, sort of what does recovery mean to them. And for some people, it's not taking any medications, not using any substances. And for other people, it isn't. And I think we should be very cautious about sort of like binary definitions around what is and isn't recovery. To me, recovery is something that to a large extent the patient defines themselves. And it's completely compatible with medication, and it's also completely acceptable for somebody to not be on medication and be in recovery. I think another question which might be coming, and if it's not, which is how long should somebody be on medication for? And the answer to that question is we don't know the answer. We use the term opioid use disorder, a singular term, when it's probably a plural condition. When methadone was first utilized in the 60s, it was understood as being a treatment for life. And there are definitely people who need to be on medication for their whole life. If they stop taking medication, the disease recurs. But there's other people who we can stabilize over a shorter period of time. Their disease goes into remission and it never recurs. And then there's everybody else in between. And we honestly do not know when we see people in clinic who's in what category. What we know from brain science, and this, I didn't get into this in this talk, but one of the sort of signatures of addiction in the brain is a decrease in the dopamine pathway that is part of addiction, and that's part of the sort of the sickness that people feel. It's not just opioid withdrawal; it's also like how the brain has temporarily changed, and that dopamine system takes about 2 years to fully heal. So when I see patients in clinic and we're initiating medication for the treatment of opioid use disorder, and a very common question is, like, how long do I need to be on this medicine for? I usually say, let's be on it for 18 to 24 months and reevaluate it then. And If somebody doesn't want to remain on medication, that's fine. We slowly taper it. And sometimes, as people go down on the medication, they start to feel unstable. And then we, continue it. So it's a lot of sort of individualized care because honestly, we don't have a very good, clear answer to that. One caveat is that postpartum period. So I think if you're going to pick a period of time that is the worst period of time to stop or taper somebody's medication, it's in the 4th trimester. It's after delivery. People, this is like, as I hope I showed, a time of increased vulnerabilities, mood changes, structural realignments with, insurance and, and welfare and sometimes housing, and it's also a time of, recurrence, opioid use disorder, recurrence, overdose, and overdose death. So really, keeping people stable through that first year following delivery, I think, is key to keeping people, one, alive, and two, forming strong relationships with their families and with their communities.
Thank you, Dr. Terplan. The final question that was submitted online was, if a person using MAT is asked by a non-medical professional to stop using it, what should they do?
So I guess I would want to know some more information about why. This would be like a friends or family person with their opinion about what they think about medication, saying, we don't think, it's not recovery if you're on medication, or some other, kind of, biased or ignorant or discriminatory statement. I think that from a recovery-oriented perspective, there are as many different paths to recovery as there are people in recovery. And there are more people in recovery from opioid use disorder who did not touch the treatment system than there are people in recovery who did touch the treatment system. And that doesn't mean that treatment doesn't work, but that means that there are multiple paths possible. And just because something worked for one person doesn't mean that it's going to work for somebody else. And I think the important thing is, as a physician, we treat the individual. We understand, the population health, and we understand the evidence, but that evidence may or may not apply to the person sitting across from us in a room. And the same is true, so just because, stopping methadone worked well for one person doesn't mean it works well for somebody else. And then we know from the evidence base, which was summarized nicely in that National Academy publication, that, continuation of medication is the most, has the strongest evidence base for recovery. Not the only evidence base, but the strongest evidence base.
Thank you, Dr. Terplan. I'm going to see if we have any other questions in the room. At this time, I think we're just going to say thank you very much for an excellent presentation. Thanks for bearing with us with the technology.
Well, thank you so much, and it's a real pleasure. And people have my contact information, and it's there so that if questions emerge, reach out to me, please do.
Yes, thank you. We'll also be sharing your information with everyone after the event via email.
Great.
Thank you. Goodbye.
All right. Goodbye.